Q&A button. And with that, it is my absolute pleasure to introduce our speaker today, Dr. Odinachi Oguh. She is a board-certified movement disorder neurologist and graduated summa cum laude from her medical school and finished her neurology residency at the University of Illinois and completed a postgraduate movement disorder fellowship at Northwestern University. Prior to joining the Cleveland Clinic in 2019, she treats all sorts of movement disorders, and her interests lie in research and clinical management of atypical Parkinsonian disorders, Choreiform disorders like Huntington's disease, as well as ataxia. So it is my great pleasure to welcome Dr. Oguh. Thank you so much for joining us today. The floor is yours.
Thank you for that introduction, and welcome everyone to this webinar. I also thank the National Ataxia Foundation for inviting me today. So let's get started. Let's talk about SCA8, and I don't know how many people who are on here who have SCA8, but let's talk about the history of SCA8 and when it was discovered. So it was first described in a research article in 1999 by a group of researchers, certainly led by Dr. Laura Ranum. She was one of the first who had described the disease. The first genetic testing, at least that has been reported and written up, was in a mother and daughter, both who had been affected by an previously undescribed type of ataxia, and certainly based on the fact that mom has disease and daughter has disease, it is an autosomal dominant type of mutation. And this was how that gene was discovered in this mother-daughter duo. And a lot of times we identify genes in large families like this by something called linkage analysis. And this is something that is used in gene discovery as well. So that's how the gene was discovered, and it certainly highlights the importance of genetic testing, which we'll talk a little bit more about. So what's the mechanism of SCA8? Who is at risk? How does it work? As I previously mentioned, it is an autosomal dominant mutation. And as we go through the lecture, I will be able to talk about some of the nuances of SCA8. We do know that it is an autosomal dominant mutation. Some of the deficits are caused by a CTG trinucleotide repeat expansion. It is one of the few SCAs, SCAs that do have a different trinucleotide repeats. Most of the other SCAs have CAG, trinucleotide repeat. SCA8 has CTG, trinucleotide repeat, which is interesting, which is important as we go through some of the genetic nuances of SCA8. SCA8 locus is on chromosome 13, and because it is an autosomal dominant mutation, it is a 50% risk per child in each family for this inherited condition. So that's something also that's very common with autosomal dominant mutations, is that they have a 50% risk per child. But that's not all the nuances of SCA8. One of the important things in SCA8 is penetrance, and that's the degree and extent of clinical manifestation in the disease. So we do know in SCA8, there is a much more maternal penetrance bias. And what does that mean? A lot of the scars or a lot of trinucleotide repeat expansions, very similar in things like Huntington's disease, have a paternal penetrance bias, meaning if you inherit the disease from dad, the expansion, there could be an expansion of that gene in the child that inherits the gene. In SCA8, that's a little bit different, and that is because it is much more of a maternal penetrance bias, meaning that there is a risk if you do inherit it from mom that CTG repeat length might grow. But there are also other factors that enhance the penetrance of SCA8. But one of the unique features of SCA8 is that maternal penetrance bias that can happen in SCA8. So when we talk about the molecular happenings in the cell, as we talked about genetic mutations, what does genetic mutation cause at the cellular level? Because when we do have an abnormal gene, and I simply explain it in the simplistic term because I know that there are a lot of patients that are on this webinar. What tends to happen at the level of the cellular, at the level of the cell, is the malfunctions that those genes causes. And typically this include things like transcription abnormalities, proteasomal system abnormalities, and synaptic transmission abnormalities. And so in summary, it causes a dysfunction at the level of the cell. And when that cell itself is not functioning properly, it leads to a lot of downstream dysfunction. So at the end of the day, genes produce proteins. If proteins are abnormally transcribed, abnormally functioning, it leads to a toxic impact at the level of cell. And so that toxicity leads to cellular death, which is the end be all of a lot of those abnormal genetic processes. And when you do have cellular death, how does it present structurally is volume loss in the cerebellum. And a lot of those cerebellar ponton and cerebellar basal ganglia pathways become affected. So that's something that's very key at the level of the cell. And when I previously mentioned penetrance, and why is this important? And there was a nice paper that was written by Perez et al. And his colleagues, which basically explained the fact that in patients or families that have high penetrance, and when we talk about penetrance, is the manifestation of the disease. So what's very unique with SCA8 is that in some patients, if there's a low penetrance, they may not present clinically with a significant disease. And while those who have a much higher penetrance will present more clinical manifest disease. And so there are some patients who have SCA8 and may not have any clinical symptoms, or maybe I would say disabling clinical symptoms, so that clinical presentation could be mild, could be slight, while those who have a much more higher penetrance will have a much more clinical manifest disease. And so the penetrance of the gene will determine the age of onset. And the reason why this is important is because in SCA8, you can have CCG or CGG interruptions in the gene. And this in itself will determine the onset of disease, the extent of penetrance. So families that have highly penetrant gene will have a much more prevalent disease in that family. So, and the higher the penetrance, the more toxic the protein is to the cells. When you compare people who have the CGG interruptions in the genome versus those that don't, you can see that there's much more cellular damage, much more, which shows up as much more advanced volume loss and shrinkage of the cerebellum, which again is that part of the brain that's involved in a lot of the cerebellar ataxias. And another thing that CGG interruptions have caused is again that RNA instability. So they increase the instability of RNA, which leads to a much more, again, earlier manifest disease, and could also lead to an expansion of that trinucleotide repeat. So again, just summarizing all I have said is, number one, SCA8 has unique characteristics of penetrance. And in penetrance, we have a high risk of the CGG interruptions in the genome. And CGG interruptions lead to more toxic cellular, more toxic levels of abnormal protein in the cells compared to those who don't have that CGG interruptions, which leads to, again, higher levels of RNA instability, leading to perhaps an expansion of that gene. Again, when you do have an expansion of the gene from one generation to another generation, means that that gene might present earlier and earlier and earlier, and hence why we sometimes have childhood presentation of SCA8. Again, this is also something very unique and interesting in SCA8. So let's talk about progression of disease. I usually tell patients that at the time they present with disease, that's actually not when the disease begins. So there is a presymptomatic stage of disease. And this can happen several decades, depending on the extent of penetrance again. If the extent of penetrance is higher, the presymptomatic stage could be shorter. If that is lower, the presymptomatic stage could be longer. So the absence of clinical symptoms is what really defines pre-symptomatic stage. So clinically, we're not seeing symptoms, but there are activities going on in the brain that is causing that drop in our neuronal pool. And so the brain has a very excellent ability to foster, to compensate for neuronal loss. And so when that tends to happen, we may not see any clinical symptoms. But by the time you begin to show clinical symptoms, that drop in the neuronal pool, the threshold is the brain's like, I can't do it anymore. And then you begin to present with clinical symptoms. So in the prodromal stage, you may have early changes in motor, in your vestibular function, which is your equilibrium. You may have changes in some of your cognitive or affective changes. But a lot of these changes, and when I talk to patients, who may or may not know that they have SCA8, they may not chalk this to a neurodegenerative disease. I think the ones that have had family histories of SCA8 are often the ones that would come in much earlier to get diagnosed, and we'll talk about that later on. So what tends to happen is this prodromal stage, you may or may not have any clinical manifestations at this time. And so, but that drop in neuronal pool continues to happen. And then the threshold at which that drop leads to more clinical presenting stage or ataxic stage is something that we are continually researching. But the impact of this, and something that we are also researching in research, is when do we introduce neuroprotective agents? Again, there's a lot of research in identifying disease-modifying treatments and how to, again, help preserve the cerebellar reserve. Because as I said, the brain itself has an innate ability to compensate for neuronal pool, a drop in the neuronal pool. There's always a certain threshold that the brain reaches when that pre-symptomatic or prodromal stage then falls into an ataxic state. And that's when you really begin to see all the clinical symptoms at this time. So again, this is again how the disease happens. Targeted structural areas that are affected by cerebellar diseases, again, the cerebellum, of course, but all the efferents, so everything that goes into the cerebellum can be affected, everything that goes out of the cerebellum can be affected, and that's why when we present with clinical symptoms of ataxia, you could also have what we call extracerebellar symptoms that are not necessarily just defined in the cerebellum itself. So how do we diagnose SCA8? I put the diagnosis in sort of 3 stages. The pre-symptomatic testing, symptomatic or diagnostic testing, prenatal testing. So pre-symptomatic testing tends to happen in patients who may have a family history, who may be aware of a family member who has SCA8, and they come in without any clinical symptoms seeking testing. Again, in the United States, it should be at the age of 18 when they can fully consent to getting pre-symptomatic testing, meaning they don't have symptoms and they want to get tested. I am really a big advocate of going through a predictive testing route. I have seen a lot of patients who may go to the primary care doctor and then get tested and maybe they become positive. And then there's a whole psychological process that happens when someone gets a positive test. We can alleviate a lot of that guilt of genetic testing by a pre-symptomatic protocol. And what does this mean? Meaning you're not only seeing me as a movement disorder neurologist, you're also getting psychological counseling. You're also getting a genetic counseling as well. And I know that there are places that don't have all 3, but the importance of having a clear conversations with your neurologist is so important, and at least having supportive community psychological support is so important. So a lot of times pre-synaptic symptomatic testing is done because number 1, maybe for family planning. So family planning, you know, I'm getting married, I want to know my state before I get married. Number 2, career. I mean, I have people who come into my office thinking about a specific career. I want to be a surgeon, for example, and I want to know what my state is before I embark in this a very expensive career route. And so I have had those patients in my office thinking about symptomatic testing. So we really take them through the route of predictive testing in terms of, you know, are they psychologically supported to get the diagnosis? Because I always feel that with pre-symptomatic testing, I always feel, okay, we should treat them as if they're going to be positive. And if they're negative, we already put things in place to help these patients. So pre-symptomatic testing is something that is done in patients who may have family history of SCA8 and are wanting to get tested for a number of reasons, as previously mentioned. Symptomatic or diagnostic testing is done in patients who already have clinical symptoms suggestive of cerebellar ataxia and are now wanting to get tested to know what genetic mutation they may have present. So again, this is also something that we do commonly. And there are some patients, even though they have clinical symptoms, may not want to know what the gene is. And I respect that. Although I often say if we have treatments in the future, we want to know what genotype you are. But there are patients who already have an idea that they have a genetic mutation, but are not entirely comfortable getting tested. And we always support them through psychological and genetic counseling as well. So prenatal testing is in someone who has SCA8 and now wants to have children. And usually this is done through in vitro fertilization, where embryos can be selected based on their genetic mutation. So we do this in a lot of genetic diseases, the advancements in IVF and in vitro fertilization. Again, if there are no biases to doing, they can be an avenue to reduce genetic risk for the next generation. So these are things that certainly one can do. So every test, as I mentioned, genetic testing has to go through a thorough evaluation by a movement disorder neurologist, genetic counseling when available. And as I've mentioned, abnormal findings of CTG, repeat expansion in two overlapping genes, which is often seen in SCA8, is something that can always be done through molecular testing techniques. And I didn't really put the labs that do this because those are things that I think when you should have that conversation with your movement disorder neurologist. So clinical care is so important in SCA8. And let's talk about some of the typical symptoms of cerebellar ataxia. And I think this is common to most cerebellar ataxia or pure cerebellar ataxia syndromes. This includes the gait and limb ataxia, scanning speech. So scanning speech is usually slow and slurred or drawn out slowness of speech. You can have eye movement abnormalities with nystagmus, which is just the jumping movements of the eye. Abnormal pursuits are basically when I ask you to follow my finger and that slowness of following finger. Saccades also can be slow. So saccades are rapid eye movements, looking from one finger to the other. So sometimes you can have abnormality of fast, rapid movements of the eye. So as I also mentioned, you can also have extracerebellar symptoms, and this could include upper motor neuron findings, meaning increased tone in your limbs, increased reflexes in your limbs, extrapyramidal findings. So sometimes, occasionally, you may have Parkinsonian-like features. It could be tremor, it could be dystonia. And dystonia is when you have a stiffness or a postural abnormality of your, it could be anywhere really, your limbs, your neck, your face. I've had patients with SCA8 who have abnormality with oromandibular dystonia, their neck dystonia, and those things can be seen in certain patients with SCA8. Brainstem signs can also happen, and this includes swallowing problems, poor cough reflex. Neuropathy can also happen, which basically means a loss of sensation in the limbs, and cognitive changes, cognitive and affective changes. So affect is your mood, can also happen. And usually in cerebellar ataxia, cognitive changes are not purely like what we see in dementia. Usually these are executive changes or processing changes. So executive changes usually fall into the route of dual tasking, ability to do two things at the same time, ability to process information from getting from point A to point B, the ability to pay attention and concentration to details of a story, are things that sometimes we find in cerebellar ataxia. Mood and affect can also be something that can also happen in ataxia. And we see this a lot, which include anxiety and depression, all the things that we can see in SCA8 and other cerebellar ataxia syndromes. So clinical evaluation always starts with a detailed history, detailed examination, and workup, which should include an MRI brain and other imaging diagnostic modalities, and then genetic testing. As I mentioned, this has to be a conversation between the neurologist, but also involving the genetic counselor, the psychologist for that support. Management options in SCA8, as there are no curative, there's a lot of research going on to find this. There are other things that we have to manage to ensure the best health-related quality of life. So PT, physical therapy, occupational therapy, speech therapy. I usually try to get this done as frequently as I can. And people sometimes will ask me, why do we need PT, OT, and speech? And I say to them, well, we want to keep what you have. We want to make sure we're harnessing all the pathways in the brain to make sure that you are physically able. Your health-related quality of life is so important as well. And of course, if the time comes when we need a wheelchair, a walker, or a cane, those things can certainly be detected earlier by the physical therapist. My goal is really to prevent any falls as much as we can, and we're giving our patients all the things to help reduce that. Dietary management is also very important. Certainly early in the disease, as well as when the disease progresses and how that diet changes. Pharmacological options are focused on symptomatic treatment. And my next slide is a busy slide, but it's not for you to memorize at all. It's really just to show the extent of drugs that we have to manage every symptom in ataxia. The National Parkinson's Foundation has a good list of this on their website. So again, this is sort of the drugs that we use in managing different types of symptoms in ataxia. So as I mentioned, all the specialized care is so important in cerebellar ataxia. I certainly advocate for a multidisciplinary approach to ataxia. What is helpful to the patients are usually having a good physical rehabilitation therapies, which include the physical therapy, occupational therapy, speech therapy. In some centers, they may have a nutritionist, a psychologist, and a psychiatrist, and then palliative care if needed. And, you know, there are ways to harness the use of palliative care in our ataxia patients, especially those who are advanced, and that can certainly be helpful to reduce that caregiver burden in our ataxia patients. I believe this is my next slide, like my last slide. I want to thank you. I'm glad that you could join us, and we are now open for questions.
Wonderful. Thank you so much for that fantastic overview of things to do with SCA8. It's a lot of information. It can be very overwhelming. So thank you for presenting it so clearly. And just a couple of questions that we've gotten. Yes, a recording of this presentation is going to be made available in about a week. So don't feel like you have to write down every single little detail. You will be able to review it at your own leisure. Additionally, for folks who have a bit more of what kind of research is coming down the pipeline, what's coming next, we are going to be having a session on that this Friday with a trainee with Dr. Laura Ranum. with that, we're going to dive right into the questions. So just as a reminder, at the bottom of your screen, there's a button. It looks like two different speech bubbles with the letters Q and A on them. So if you want to drop your questions into that, we're going to get started. So first, we have a series of questions relating to inheritance patterns and penetrance with SCA8. So the first one being, you mentioned that if one parent has SCA8, there's a 50% chance of the child having SCA8. If both parents have SCA8 diagnoses, though, is it still a 50% inheritance patterns, or is the likelihood greater?
That is a very good question, because you need 2 copies of the genes, because in autosomal dominant mutation, you need only 1 copy of the gene. So I think that's only a very good question. I don't know if the risk is higher than 50% per child, because you really only need 1 abnormal chromosome to inherit the disease. Now, if you inherit both copies from the parent, is that even survivor for life in that child? And so that is a very interesting question, but the risk does not increase because you only need 1 copy for that child. But if there's a double whammy, as we often say sometimes in medicine, is that even if that embryo able to even achieve life?
No, that would be very severe, a very severe form of the disease.
Correct.
Yeah. So our next question is, so you mentioned that risk factors when you know a parent has SCA8. Does it matter whether or not your parents' siblings have SCA8? Does that increase your likelihood of inheriting it yourself?
That's a good question. The answer is, if your parents don't have SCA8, so because it's an autosomal dominant mutation, there has to be a direct line of inheritance from the mother or father to the child. So it could be that your parents or your mom or dad may not have SCA8, so you don't get it. But of course, there's that strike and lightning situations that do happen where you get a spontaneous mutation in SCA8 and you develop SCA8. But if your uncle or aunt has it, then you from your other parents will not have it unless you have a direct inheritance from your mom or dad. So their children have that risk of inheritance in that child, in their own children, but not you as a niece or nephew.
Okay, that's good to know. Our next couple of questions relate to penetrance that you were speaking about earlier in the presentation. Do genetic tests for SCA8 determine penetrance strength, or is that predictive in any way?
So predictive if you develop disease earlier, meaning because we do know that the presence of CGG interruptions in the genome result in much more earlier manifest disease. And we do know that people who have CGG interruptions, they present earlier irrespective of their repeat length. So that is so important in early clinical manifest diseases, and there are labs that can identify if they have that or not.
On that topic, if someone goes for genetic testing, gets the repeat sequenced, are they provided is it a yes/no answer they get? Are people provided information about their exact repeat length, or is that available to their neurologist? Could you talk us through that?
So when you have genetic testing, any of the trinucleotide repeats, you should have a picture of a report that looks like this. You have an allele who has 18, which is your normal allele, and then you have another allele which is over 50, 60 repeat lengths, right? So you know that you have an abnormality in that other allele. So that's usually what we see in that report. So yes, a good genetic lab should be able to give you the specific numbers in that lab.
And then just to clarify, we have a follow-up question from someone. So is it, if you could explain penetrance again, we have someone who's asking, if you have the mutation, does that mean 100% that you're going to develop symptoms?
Good. So let me repeat that question. So if I have disease, if I have genetic mutation, is it clear that I'm going to develop symptoms?
Yeah.
So as I mentioned earlier, there are some patients who have very low repeats. And low could be, 30 to 40 or something in that number.
Mm-hmm.
The clinical manifestation of their symptoms could be 0 to none. But we also living longer. Mm-hmm. So you could present the disease much later in life. Mm. So that can also happen. But patients who have higher penetrance, we often see in that group of patients or group of families that they have this CGG interruptions in their genome. And so the presentation of clinical manifest disease is much earlier.
Okay.
So we do know, irrespective of their repeat length, if they have these interruptions in their genome, they will present way earlier than their regular counterpart who doesn't have this interruption.
That's very good to know. And then our next question is around onset of symptoms and what does that mean in terms of disease progression. So we have one attendee here who's had a child who's had symptoms since birth, and they're wondering, since symptoms have started so early, what does that mean in terms of disease progression and course of life?
So certainly the younger you present with symptoms, the longer the duration. So, the earlier you present with symptoms, the longer the duration of symptoms. And that also comes with more disability from the disease itself. So certainly without knowing the repeat length,
of course,
I would say that, and if they have, CGG interruptions in the genome, that in itself, just having it at a younger age will tell me that the duration of the disease is longer. The impact from the disease, the disability from the diseases also could be much more severe compared to someone who may develop disease later in life.
And usually, if you could just remind us again, around what age do most folks start experiencing symptoms for SCA8?
Usually mostly in depending on the repeat length, usually most patients will develop disease either 30s, 40s in terms of their symptoms, in terms of development of the disease.
That's very helpful to know. And then we're just going to make a slight deviation into some more, and thank you for all the questions that are coming in. We're going to try to get as many as in the next 20 minutes as we can. We're going to shift over to some symptomatic questions. So we have an attendee here who's interested in knowing, for all the symptoms related to SCA8, are all of them progressive, or are there some things that will remain the same sort of deficit or challenge throughout the course of disease, or does everything get worse over time?
It is a slowly progressive condition. So depending on the extent of the symptoms, some can be at a certain point in that progression worse than the other. And so your motoric symptoms, which is the limb and gait ataxia, tend to have a slow progression. Mood symptoms or some of those affective cognitive symptoms, they may not have a very linear progression. It could be sort of I call it a wave. You could have fluctuations throughout the disease, depending as well. So, but in terms of more of that motoric symptoms, which I think the attendee is asking about, is usually much more of a slow linear progression over time. Yeah.
Oh, that's good to know. And then we have another attendee who is interested. Have you heard about people with SCA8 experiencing violent coughing? And if that's the case, what kind of options are there for folks to have symptomatic treatment for that?
So violent coughing is usually a reaction or symptom of something else. And I did mention in my extracerebellar signs that you can have a reduced cough reflex. You can also have dysphagia. So usually when you have a reduced swallowing reflex, I would suspect that the coughing is as a sign of that, maybe an impaired swallowing. That would be my impression of that violent coughing, because then they always feel that there's something behind their throat. You do need a good thorough evaluation by perhaps a speech therapist, having a swallow study. Things like that would be something to really determine. Now, can you also have coughing reflexes from that irritation of the vagal nerve that is behind that throat? Again, there's so many things that I would have to consider in someone who is insistently coughing.
So it can be helpful to connect with your neurologist or a speech pathologist who have expertise in this area to narrow down what's exactly causing the symptom.
Correct. Yeah.
That's helpful to know. And then we have someone here who's interested. She has SCA8 and she also has spasticity. She's interested in learning if other SCA8 folks, if this is common, and what kinds of symptomatic treatments are available for folks who are experiencing spasticity.
Spasticity is very common in any cerebellar condition. I see that a lot in my cerebellar patients. So we treat them by a variety of things. So let's talk about oral medications for spasticity. We have things like baclofen, which is really geared towards spasticity, but of course this doesn't come without its own side effects. And sometimes we use things like tizanidine or Flexeril, and I'm calling names right now that are common to the United States. But some of the Flexerils and tizanidine are really much more muscle relaxing, so they may not give you that spasticity relief. But they're also without its own side effect profile, like fatigue, sleepiness, and nausea that can happen with medication. And then other options that we do have is botulinum toxin. So we do Botox in patients with spasticity, whether you have cerebellar ataxia or not. And so botulinum toxin is FDA approved for both upper limb and lower limb spasticity. So we do use that. I prefer that because it doesn't have all the side effects from oral medication. And along with using pharmacological medications or botulinum toxin, I'm a big advocate of having a physical and occupational therapist, because depending on the extent of spasticity, even if I do Botox, I will still need some stretching and things like that. And the PTOT can help me with specific orthotic prosthetics to help with keeping that limb nice and relaxed. So there are so many things we can do with spasticity and cerebellar ataxia.
Since you mentioned some of the supports that OTs and PTs can give to folks with SCA8, that connects with our next question. So we have an attendee who asks, what would you say to loved ones who are opposed to a patient's need for a wheelchair? Is that a 100% guarantee that they're going to stop being mobile?
So we often recommend wheelchairs for safety, right? And you don't have to be constantly in a wheelchair. So a lot of my patients will come in, and because we have a great physical therapy here at Cleveland Clinic, I'm always sending them there. And so they are able to tell me, okay, the patient needs a walker or a cane or whatever that need is. And then sometimes they'll tell me, they're walking long distances, going to, a doctor's appointment or things like that. And maybe they would need a transport wheelchair to supplement what they're doing with whatever walking assisted devices. So again, at that time, they're not constantly in the wheelchair. But at a time when they need more constant wheelchair, I think that's a conversation that we all often have with the patient, because at that time, despite all our best efforts, they're falling, they're injuring themselves. I always tell them, okay, maybe it's time for a wheelchair, but that would make you a little bit more independent. And then you don't fall and break something, and then that takes you back, right? Because when you fall and break something, that really affects
Yeah.
your disease as well. So I often will tell them that. And so a wheelchair is not the end all be all. It is a conversation that we have to have. And having a wheelchair can actually make you more independent. So we have power wheelchairs that you can maneuver yourself. You can also have your caregiver maneuver the power wheelchair as well. So that gives you ability to help with that, with mobility.
Mm-hmm. So from what you're saying, it sounds like different assistive devices like wheelchairs and canes can really, they're tools to help you live your best life and get where you need to go and preserve
Correct.
energy.
Yes.
No, that makes. Speaking of energy, we have a question from someone who says that they have SCA8 and they have a lot of fatigue without any sleep abnormalities or other health issues. Is fatigue common for folks who have SCA8?
Yeah, and fatigue is common in all neurodegenerative diseases. Unfortunately, you do have intrinsic factors due to the disease itself that cause fatigue. And sometimes we don't have a great therapeutic option for fatigue. Oftentimes we try to sort out the secondary risk factors for fatigue, as the attendant mentioned, sleep, a discussion about sleep, a discussion about their mood, anxiety or depression that can be happening, that can affect their sleep, their fatigue, and also just their nutrition as well. So all those things are things that we can perhaps fix, but if it's more intrinsic to the disease, sometimes, even with the best medical therapy, that can be difficult, but we do try some therapies to help with fatigue if it's very disabling.
And then we have a follow-up question for that. If there are folks with SCA8 out there who are having trouble with sleeping, what are some of the things that you recommend people start to explore or discuss with their care team?
So I think the first thing is trying to figure out what's causing you to sleep. So my go-to is not always medication. So I try to figure out, okay, sleep hygiene. What are we doing before bedtime that is interrupting our sleep? Do we have anxiety about sleep? Because that in itself can lead to a psychophysiological reaction and causes us insomnia. And then are we waking up at night, and I'll be having ruminating thoughts, things like that. So those are behavioral changes that we would need a sleep psychologist to try and fix before we even get to the point. And then we have to think about, are there any primary sleep disorders, obstructive sleep apnea present? Because not just obstructive, but you can also have central sleep apnea as well in cerebellar ataxias. So those are things that we would need a sleep neurologist or pulmonologist to try and help us with. And then you can have circadian rhythms of sleep, disorders of sleep, that, parasomnias to REM sleep disorders as well, that we have to sort out as well. So those are primary sleep disorders that we can have to require more specialized care in terms of trying to figure those out. And so those are things that can happen. But I do know there's a lot of chronic insomnia and scars as well. So again, as I said, a sleep psychology might be helpful in those patients.
And then we have a couple more questions around symptoms and some of the management of them. Do folks with SCA8 develop dementia?
That's a good question. And I want to understand if it's dementia in the true word of Alzheimer's or other types of dementia. I truly dislike having two diagnoses in one disease, but it can happen where you have all the types of Alzheimer's dementia. Is it the disease itself? I think the data on SCA8 tends to be more cognitive executive dysfunction in patients with SCA8. And I think that those are things that we often tend to look at and see in my cerebellar ataxia patients. I certainly do know that I think just thinking just in my experience, maybe one patient I have had out of all the hundreds of patients treated that may have had some sort of dementia, but we didn't really appreciate that to be Alzheimer's dementia. So I think it was just a very severe cognitive impairment due to the disease. But that's not common. I think what we tend to see is just the executive dysfunction, mild to moderate cognitive changes.
Oh, that's helpful to know. And then we have a couple of people who asked the same question with slightly different wording. So if I'm not answering your wording, it's because I'm using someone else's. But we have some folks who are interested in if SCA8 can cause loss of bladder or bowel control, or if frequent urination can be a symptom.
Yeah, so not just in SCA8, but in most cerebellar ataxias, you can have a spastic bladder. So the same thing with that spasticity is a very irritable bladder. So you're going frequently, urgently to the bathroom. So we do see that at the end stage of that, you could have incontinence as a result of that. So essentially, we do see urination abnormalities in patients with scars, not just SCA8. And there are ways to treat that. Whether we're doing oral medications, again, all oral medications have risk and benefits with them. And I think there's a good list on the National Ataxia Foundation about meds that can be used. And there are newer ones. Now, again, I'm calling the US name, like Mobettric, which we often use in patients with spastic urination. And then there are stimulators. Sometimes patients try that to see for help with their bladder, but I always send them to a specialized urologist to help with that as well. We also have Botox for spastic bladder. So there are many things you can really do to help with frequent urination.
Well, thank you for that overview of the different symptoms. We're going to move on to questions relating to different lifestyle modifications. So we have an attendee here who, in your presentation, you mentioned diet, and this attendee would like to know what sort of diet should folks with SCA8 have? Is there anything that they should be avoiding in particular or seeking out to include in their diet in particular?
So I'm going to take you back to the data that recently, well, I don't know if it's recently, but in the last few years that have come out about neurodegenerative diets and what that should look like. So of course, the biggest data in diets are the Mediterranean diet. And then now we have the MIND diet, which is an offshoot of the Mediterranean diet. And the MIND diet has the one that has been studied greatly in neurodegenerative diseases. And it's not just unique to scars, but unique to the whole host of neurodegenerative diseases that happen. So it's called the MIND diet. And there is a lot of data in lifestyle and diet in helping a lot of neurodegenerative diseases. So that's really my advocate. And again, a lot of diets I had to stick by. So I always tell my patients, if you have some sort of foundation of what diets should be on, I think that is key. So again, a little bit more plant-based, again, avoiding ultra-processed foods, things like that. That's sort of the key elements in some of the Mediterranean and MIND diets that we do have. But lifestyle in general is so important. Exercising is so important in these diseases, because if you don't use it, you lose it, especially if you have a neurodegenerative diseases. And that's both mentally and physically. So you want to make sure that even after we send you to physical therapy, occupational and speech therapy, you are taking part in those exercises at home. I do remember a patient in the last national conference that we had who said, I have this disease, but I didn't let it stop me. And she could have had milder disease, right? And oftentimes she would tell me, I did everything, kickboxing, I did karate, I did everything. And suddenly, she did have a lot more manifest disease as she grew older. But again, she said she tried to make sure she was physically active with her disease. And I think that's key. I do see patients, if they don't follow up with me in a year and they haven't been active, there is a decline that tends to happen. Because again, if you don't use it, you lose it. So lifestyle is so important in this disease. Two vitamins that we often prescribe it for patients in many types of scars, the coenzyme Q10 and vitamin E. And so those are the two vitamin supplements that if someone asks me, what should I take in terms of vitamin, that would be what I would recommend.
Mm-hmm. That's very helpful to know. I know it can be hard to stay on habits and develop those habits, but it's good to start them early. And you mentioned in your presentation, we have a couple of people who've asked this question about neuroprotective or different protective agents that you should start, or things you should begin before you start experiencing symptoms. Can you speak to that, whether that's lifestyle modifications, diet modifications, or different pharmaceutical treatments that people should be starting before they have ataxia symptoms?
That's a great question. And I put those neuroprotective statement because what we do have now is really lifestyle modification and diet. There is still a lot of data looking at other neuroprotective agents. And I think the key is that by the time we already have clinical symptoms, there's already a loss of that neuronal pool. So I think there's a lot of research, and I think Dr. Laura Random will talk about it, is looking for biomarkers in diseases so that we can pick up earlier manifestation. It certainly helps if they have a family history, but there are some that may not know their family history. And so biomarkers will be very important in establishing neuroprotective agents in a lot of the cerebellar ataxia. So those are things that are going to be very important, but diet and exercise are what we have right now to help neuroprotection.
That's helpful to know. So it's something that to keep an eye out for in the future.
Correct. And I'm going to say this because I know I get a lot of questions on stem cells and whether they help or don't help. Are they neuroprotective or not neuroprotective? There's no data on that right now. We do know that a lot of the stem cells in the general commercial space is mesenchymal stem cells. Mesenchymal stem cells do not convert to neuronal stem cells. They are blood stem cells. Do they make you feel great when you do them? Perhaps they do because they are anti-inflammatory in nature. So we have a lot of patients with, oh, my pain is gone, but did it help your ataxia? No. So those are things that I usually get asked on in the clinic. So that's why I mentioned them. There's some data on using neuronal stem cells, and neuronal stem cells, you can only get them two ways: embryonic stem cells or harvested stem cells from your skin fibroblasts. So there is not in the attacks, there is two big trials going on in Europe, I believe, and Japan that are looking at, one is using embryonic stem cells for a variety of disease, specifically Parkinson's disease, and Japan is trying to reprogram stem cells from the skin fibroblasts. So those are the only two clinical trials that I have, but there's a lot of stem cell tourism that happens, and we see them because we're in Vegas and we see those patients. And so it's just something that there's no data right now to support stem cells in cerebellar ataxia, but there will be a time when stem cells would be available, but not right now. It's not ready for prime time.
Okay, so it needs to cook a little bit longer, or whatever the expression is. It needs a little bit more time in the oven to develop. The science needs to progress before we know that it's safe and effective.
Correct.
Well, that's very helpful to know. And with that, we are at the top of the hour. So for folks, if we didn't get to your question, my apologies. If you would like to reach out to research@ataxia.org, please feel free to reach out and we can try to help you in any way that we can. And if everyone could join me at their own individual computer screens, thanking Dr. Oguh for her time and sharing her expertise with us. And so thank you so much for coming here today and presenting with us. And thanks to all of you for joining us and listening to this session.
Thank you. This was very exciting. I hope I shared some knowledge and impacted some knowledge to everyone.
Well, thank you so much. And wherever you're joining us from today, good morning, good afternoon, good evening. Hope you have a wonderful rest of your day. Bye, everyone.